Good day, friends, and a warm welcome to the 43rd episode of 4D, that is, Detailed Discussion and Dialogue in Diabetes, in Indian Diabetes. Today, we have an expert with us, a person whom I look up to as a teacher, as a master clinician, and he is Dr. Suraj Prakash Sondi. So, warm welcome to Dr. Suraj Prakash Sondi, SP Sondi sir from Meerut in Uttar Pradesh. Dr. Sondi sir did his MBBS from Meerut, the Government Medical College in Meerut, received 4 gold medals. He didn't leave anyone for anybody else, and then continued his studies there to do MD medicine. He is currently guest faculty at the Department of Medicine in Subharti Medical College, Meerut. He has been a course coordinator for certificate courses in diabetes run by the PHFI, Public Health Foundation of India, and also the V. Mohan Diabetes Research Federation. He has been investigator in multiple single center and multi-centric trials. And his name in public education, his work in public education is something that we all look up to with awe. Warm welcome, Dr. Sondi sir. Welcome to the show, and we look forward to learning from you.
Good evening, friends, and I am Dr. Sondi from Meerut. I am a general physician and a diabetologist working in the field of diabetes for the last 43 years. And I'm thankful to Sun Pharma and IJCP for giving me this opportunity to talk about one of the not so commonly discussed complication of type 2 diabetes. And in the next few minutes, I will elaborate what I'm trying to say. Can I have the slides, please? So this is looking beyond endocrine. Whenever we talk about type 2 diabetes, we know and we rightly think that this is an endocrine disease. But, sometimes you have to look beyond endocrine and clinical practice when we are not happy with the loss of weight. And I very strongly remember this quotations from White's pathology, which says your eyes don't see what your mind doesn't know. So you have to know a sign, you have to know a disease before you can see it. The disease may be right in front of you, and you may not be able to register it in your mind because it's not in your mind. So we talk about a lady, a 66-year-old lady who came to my clinic with type 2 diabetes mellitus for the last 12 years. She was also hypothyroidism on treatment, but her main complaint was 15 kg weight loss in last 6 months. The weight actually came down from 55 kg to 40 kg. Her appetite was normal and she had no fever or cough, and stools were normal. She was passing stools 2 times a day. So, whenever we are trying to solve a mystery, we must have the options or the culprits in our mind. So let's look at what are our differential diagnosis in a case of type 2 diabetes who's losing weight. Well, the culprits could be a very badly controlled diabetes, which means that the patient's carbohydrates are not being consumed properly by the patient because of deficiency of insulin or resistance to insulin, and most of the glucose is passing out in the urine without being consumed. So in that state, there is likelihood of a loss of weight. We see that condition in many type 1 diabetic, but we seldom see this condition in type 2 diabetes. But yes, some type 2 diabetes who are very badly controlled can have a diabetic cachexia or a diabetic weight loss caused by uncontrolled diabetes. And then, of course, if our diagnosis is incorrect and we are not dealing with type 2 diabetes, but type 3C. What do we mean by type 3C? Type 3C means pancreatic diabetes. So most of the pancreatic diseases like chronic pancreatitis, pancreatic carcinoma, or pancreatic surgeries can result in type 3C or pancreatic diabetes, which will have both endocrine and an exocrine dysfunction of the pancreas. And, obviously the patient will have steatorrhea and weight loss, etc., etc. Weight loss could also be due to prescription drugs because of anti-diabetic drugs. Now we know that there are many drugs which cause weight loss, which is actually advantageous in most of our obese patients, but in some normal weight patient, they complain of weight loss, especially if you give them GLP-1 agonist, or if you give them metformin also causes a 2 to 3 kgs of weight, and so does SGLT2 inhibitor, which may end up in 3 to 4 kgs of weight loss. And when sometimes you combine these two, the patient can lose weight because of the drugs which you are given. Often we forget that diabetics are more prone to cancer, that very high blood glucose levels, can actually cause disruption of mitochondria as well as and can cause more cancer. If you go into the statistics, many cancers are 2 times more common in diabetics than in non-diabetics. And not only they are common, but their mortality is at least 2 times if the patient happens to be a diabetic. So we got to keep the cancers in mind if there is a diabetic patient who's losing weight. And then a diabetic patient can also have other diseases like tropical sprue, celiac disease, etc., etc. And then in the end, another less known complication of diabetes, about which I'm going to talk to you about in next few slides. Coming back to our patient, this lady was on thyroxine 50 microgram, was on pioglitazone 7.5 milligram twice a day, was on linagliptin 5 milligram once a day, and was on metformin 500 milligram a day. Now, if you will agree that none of these can actually cause weight loss. Pioglitazone will cause some weight gain, linagliptin is weight neutral, and metformin in a 500 milligram per day dose hardly causes any weight loss. And thyroxine, she's on thyroxine, so sure, if the thyroid level is not euthyroid, then she can actually have weight gain because of badly controlled hypothyroidism. If you look at her reports, her hemoglobin was 10.5, which was a microcytic anemia. Her A1C was excellent, 6.1, excellent control. So we rule out diabetes-induced asthenia or weakness because the diabetes is absolutely very well controlled. Even TSH is normal. So even hypothyroidism, badly controlled, is not in this case is causing weight loss. LFT is normal. Lipids are nearly normal. Transferrin saturation is low, which means there is some iron deficiency. Vitamin B12 is low and vitamin D is low. We see a lot of low vitamin D in almost 90% of Asians and Indians. And we see a lot of low readings of B12 in vegetarians. This lady happened to be a vegetarian. X-ray chest was normal, ultrasound was normal. So we went ahead, got a HIV, HbS, HCV done, viral markers, because one of the reasons for weight loss could be HIV. Then we were trying to, find out if she had any cancer. So CA125 CA was normal. And for celiac disease, we got an anti-TTG done, which was normal. The upper GI endoscopy and CT abdomen was done again for searching out some, hidden cancer or anything, was normal. And then we did the diagnostic test, which many of us do not do. And this test was fecal elastase. All of you know that this test is done for pancreatic exocrine deficiency, and we normally do not anticipate this in endocrine disease of pancreas, which causes type 2 diabetes. In this case, it was very low. The normal range is above 200, and this lady had 42 microgram per gram of stool. What exactly is the sensitivity and specificity of this test? And why was this test positive in her when she did not have chronic pancreatitis or anything? Why did she have this? Well, if you look at the sensitivity and specificity of the test, in mild to moderate cases, the sensitivity is about 65%. In severe cases like our case, it is 100% sensitive. And as far as specificity is concerned, it has a 90% specificity. That means if it is positive, it is the chance is 90% that the patient is having exocrine pancreatic deficiency. We know from our school days that there are many ways of assessing exocrine functions of pancreas. The oldest one was fecal fat estimation, which was not a good test because you got to keep the stool, collect the stool, keep it in the fridge for some time, and so on and so forth, and ask the patient to take a very regimented diet which contained regimented controlled fats. So this is one test which is very sensitive, very specific, and it is very widely used. Why? Because it's cheap and non-invasive and widely available. As far as cheap is concerned, it's affordable. So at some places this is costing about 2,000 rupees, and other places it's costing 4,000 rupees. So it's between 2,000 to 4,000, but it's worth spending that money. It's a pancreatic enzyme that's not degraded during the digestion. So pancreas makes elastase and it is not degraded during digestion. And this comes out in the stool. It is not affected by the enzyme use of the patient. It does not require a timed stool collection. That means 24 hours. It's done in a spot sample. It does not require a special diet. And day-to-day variation is very little. Less than 15%, and sample can be easily stored. So it has all the properties of a very affordable and very effective and very easy test. Why in this patient of type 2 diabetes we had exocrine deficiency? Well, we diagnosed exocrine pancreatic dysfunction in this lady. And this is what I wanted to talk to you about today, that when we are dealing with type 2 diabetes, we are dealing with the endocrine dysfunction. But many of these patients will have associated exocrine pancreatic dysfunction. We will call it exocrine pancreatic dysfunction when there is malabsorption process resulting from either inadequate production, release, decreased activation, or insufficient degradation of enzyme required for digestion from pancreatic acinar cell. And fortunately, exocrine pancreatic dysfunction does not occur as long as the pancreatic enzyme's activity does not fall below 10% of normal. That means the 90% of this is when the pancreatic enzyme comes down to about 10%, then you notice, and then we notice the symptoms and signs of exocrine pancreatic dysfunction. Well, if you look into the studies done with fecal elastase, this is a meta-analysis, and it tells you about the range of exocrine deficiency as assessed by fecal elastase 1 in diabetic patient. In type 1 diabetes, approximately 38% had exocrine pancreatic dysfunction. In type 2, it was slightly less, but as high as 26% had almost 50% had severe deficiency. So out of those 26%, 13% had severe deficiency and 13% had mild to moderate deficiency. So 26% is not a small number. If you go into your memory and say which is the commonest complication of diabetes, the commonest complication of diabetes like neuropathy will be seen in about 24-25% patients, and this is almost equally prevalent. Why do we not diagnose it? Because we don't think about it. Well, why does it happen? Well, there are many theories or hypotheses which have been given as to why a small dysfunction of beta cells or islet of Langerhans can affect the 90% of the pancreas. And there are various ways. One theory is that the hormones which are secreted in the endocrine part of the pancreas affect the exocrine part as well. And the biggest one is the insulin. And they say insulin is very important for the health of the exocrine dysfunction. And then, of course, there are various theories. There is theory of inflammation, autoimmunity. There is theory of fibrosis. There is a theory of autonomic neuropathy causing this exocrine pancreatic dysfunction. And then there is microangiopathy causing this. So there are various theories, but it is not a very uncommon presentation, and I'm sure that many of us are actually missing it. If you are able to diagnose it, how will you treat it? Before the treatment, I must emphasize, and that slide is missing, that in many of the patients, the symptoms are very mild symptoms. Bloating of abdomen. It's not diarrhea. It's just bloating of abdomen, distension, weight loss, which presents. So we have to have a very high index of suspicion. How do we treat it? Well, in the treatment of exocrine pancreatic deficiency in type 2 diabetes, a change in lifestyle is required. Smoking and alcohol have to be banned. Appropriate dietary regimen, frequent but small amount of nutrition, because there's not much of exocrine function left. Normal intake of fat and intake of fat soluble vitamin, which will become deficient in these patients. And of course, very, very important, we have to go ahead and do a pancreatic enzyme replacement therapy. And if necessary, give it along with proton pump to protect it from the acid. Well, PERT is provided by taking pancreatic enzymes in an encapsulated microgranule form and mini microsphere structure with one's main meals and snacks. The main goal of the treatment is to improve the digestion and to decrease the morbidity and the mortality which is occurring because of the exocrine dysfunction. And we are coming to just last couple of slides. The typical dose is 50,000 unit with the first bite of each meal, or you can divide it. Half the dose can be given at the start and half in the middle of the meal. And if you are trying to cover the snack, it could be just half the dose of this. And if it is not an entry-coated preparation, we will protect it with proton pump inhibitor. Well, this is a very significant question that when we do pancreatic replacement therapy, does it improve the blood glucose control as well? Well, in some small studies, it has been shown to improve the type 2 diabetes status, but in others, it has not been. So that answer is still not there. So, dear friends, in the end, I will just like to emphasize that if you have a type 2 diabetic patient who's losing weight for no rhyme or reason, and even if he has a very mild abdominal symptom like bloating, like a little bit of diarrhea here and there, like a little bit of pain in the abdomen, please go ahead and get this excellent test done to diagnose pancreatic exocrine deficiency. Thank you very much.
Thank you, Dr. Sondi, for that wonderful lecture. And these pearls of wisdom that you have shared, they come only from experience. So it's a combination of education, experience, and also being person-centered. I think what I've learned, Dr. Sondi sir, from you today is that we should be able to listen to the patient with both ears open, and we should be able to look at the patient with both eyes open. And if we are able to do that, then I think the diagnosis is made. Then we know how to move forward.
Absolutely, Dr. Sanjay, and we got to spend some time with the patient, and keep a plan in our mind of differential diagnosis, and not jumping to a conclusion, but kind of reaching the conclusion.
I am reminded, sir, of this neurological syndrome known as Balint syndrome. So in Balint syndrome, there is a condition known as simultagnosia. Simultagnosia means you can see a picture of a man in front of you, but you can't see the woman or lady next to him. You can see the picture of the lady in front of you, but you can't see the man. And together you can't make it a family or a couple. So you see just one thing at a time. So, Dr. Sondi sir, do you find in practice that we are all guilty of simultagnosia? We look at just one aspect of the patient and then we sort of become agnostic to the other things that are right in front of us.
I I totally agree with you, and I think that one of the reason is that we are in a hurry. We are seeing too many patients, and we are in a hurry, and we are not spending enough time with the patients. So if we are not able to do that, I think someone of our junior colleague or paramedic can do that, and listen to most of the complaints of which the patient is having.
So, sir, some questions coming your way from the audience, and the theme is simultagnosia, how to prevent simultagnosia. So, let us begin with the entire umbrella of diabetes care. And the first thing is mind-body medicine or biopsychosocial model. So, sir, any experience from your OPD in the last week, in the last 1 year, anything that you remember, where you did spend time to take a psychosocial history and that helped you improve the biomedical outcomes of your patient? Anything that comes to your mind from your OPD?
I not as an event or something, but I think discussing whatever you are going to do with the patient and his disease has many times given me a lot of inputs about how the patient is behaving at home and things like that. And I have learned many things. So when you talk to the patient, and let me give an example. I had a friend of mine who's a diabetic, and she's around 52 years old, and she was in a high doses of insulin, GLP-1 agonist, and other things, and not being controlled. And she is little fat, but she tries to manage and things like that. And suddenly I found her being controlled very well, and the insulin requirement came down, and I said, what happened? And then she told me that she went on a very special diet which cut down dramatically her calories and other things. This was a special diet of some dietitian. And so that sinks in you that how important is diet and exercise in the management of type 2 diabetes, that we many times forget.
And other things also, sir, any time in your OPD that the patient came in with change in glucose levels, increase or decrease, and there was nothing related to your drugs. The drugs were fine, but there happened to be a medical issue, maybe hepatic, cardiac, renal, and that was causing the alteration in glucose levels. Any time that this has happened?
Absolutely. And many times that happens. And most of the time, if you ask me, it is some emotional distress at home. Something happened at home. Husband died or wife died, or there was some event happening and the patient is not able to sleep properly, and then you find the blood glucose goes up and down.
So, so far, the pearls of wisdom we are getting is, first of all, ask for emotional history. It is possible that the husband and wife are fighting with each other. There's an issue at home. A new daughter-in-law has come, or a daughter has left home. She's got married, and these actually influence glucose levels. Then, if we talk only of and then if we talk of the biomedical aspects, do talk about diet. If there is a sudden change in diet, obviously there will be a change in glucose levels. Sir, how about medical issues? Cardiac failure, hepatic failure, renal failure. Are these happy events for the patient sometimes?
Yes, I think all these
actually is in trouble.
I think all these are linked together, and all these, like a event in the pyelonephritis or something, or this and that, will upset and the blood glucose control. And one thing is sure, that every time the patient comes to us, we have to have some kind of algorithm in mind or protocol in mind. And unless we are protocol driven, that means have we checked the renal parameters, have we checked this, have we checked that, And unless there is a protocol that like that, has the patient got a fundoscopy done or things like that? So we should have a protocol in our office and in our practice. And renal, of course, and cardiac is extremely important. And I almost think that if you have a prescription of type 2 diabetes where EGFR is not mentioned on the top, that's an incomplete prescription.
Yeah. So mind-body medicine, and then medical issues, dietary issues. Sir, in medical science, one aspect is endocrinology. So the person with diabetes who suddenly develops hypoglycemia or hyperglycemia, would it make sense to check for adrenal function, to check for thyroid function?
I very clearly remember a few patients of mine who had suddenly started going into hypoglycemia for no reason, and then when we diagnose adrenal insufficiency in those patients, very rightly, and yes, these are the things to watch out.
So, with all this in mind, sir, now again, if you could share some take-home remarks regarding the exocrine pancreas. Now, sir, this pancreas, 170 grams roughly, the exocrine and endocrine aspects have been put together anatomically. You've also mentioned that there is a functional connect. I mean, if there is an endocrine deficiency of the beta cell, there are more chances of there being an exocrine deficiency also of the exocrine pancreas. So evolution must have thought something before putting these together. So if you could just, yeah, yes, sir. Carry on.
Absolutely. The people who have done studies on MRIs and CT scans of pancreas of these individuals, they have compared the size of pancreas in a diabetic to a non-diabetic and found that diabetics normally have a smaller pancreas. So now these smaller pancreas cannot happen because of just endocrine issues, because that is just islets of Langerhans are just a very small part of the pancreas. So that will not make any change in that pancreas. But yeah, I think we have to understand that most of our organs and most of the cells within an organ are talking to each other. Yes. To give you an example, if you remove an uterus in a lady, you do an hysterectomy, whether you leave ovaries behind or not, after a couple of years, they come to know that their uterus is not there and we should stop working, and they stop working.
Ovaries stop working. That is true. Sir, we are separated, you and I, we are separated by the Yamuna River. So where I practice, this is one of the richest districts of the country. Yet I see a lot of pancreatic diabetes. So now see the challenges that I face in my OPD. I see pancreatic diabetes per se. The books say that it doesn't exist anymore, but we see lots and lots. You just have to have the eyes to look for it. I also see type 1 diabetes with exocrine pancreatic insufficiency, like sir has mentioned. And we also see type 2 diabetes with exocrine pancreatic insufficiency. So these are three things. Sir, in my state, for pancreatic diabetes, when the patient walks in, you look at the patient, you are able to decide the ethnic group, you are able to decide the socioeconomic group, and a couple of sentences in history, which the patient himself volunteers. And 90% of the time for me, it is a him, not a her, for pancreatic diabetes. Usually it is men who present. You are able to know in which patient you should get the imaging done. And then either you will have a shrunken pancreas or you will find calcification or both of the above. Sir, does this work in UP as well? Can you describe a phenotype, social phenotype and a physical phenotype of people with pancreatic diabetes?
I totally lost you in between. So will you repeat what you were saying? I lost you in between.
So sir, we see patients with pancreatic diabetes and pancreatic exocrine insufficiency. We also see patients with type 1 and type 2 diabetes who have got pancreatic exocrine insufficiency. Our question was, can you give us a social phenotype or a physical phenotype of patients with pancreatic diabetes? In Karnal, where I work, it is the lower socioeconomic strata, people coming from villages, from one or two specific ethnic or caste-based groups who will have a lot of pancreatic diabetes. So the moment they walk into the OPD, our index of suspicion goes higher. And I know that, yes, I have to work up for pancreatic diabetes, not for type 1. So does the same operate in Uttar Pradesh?
Yes, I totally agree. I somehow in the place where I am working, I see less number of pancreatic diabetes, right? So that's not, of course, type 1 diabetes and type 2 diabetics are all there. And uh, as far as their exocrine dysfunction is concerned, this particular entity was not in her mind 5 years back. So I was diagnosing it very less, and so I think I have started diagnosing it much more once it's come to my mind. I have always been interested in diabetic nephropathy without proteinuria, diabetic heart failure with preserved ejection fraction, and endocrine type 2 diabetes with exocrine dysfunction. So these are my interests. So keep getting these patients. I'm as excited about heart failure with preserved ejection fraction, because this is almost half the heart failure will be with preserved ejection fraction.
This is nice, sir. And all these points that you are sharing, they help us open our mind. And on behalf of everybody who has logged in today from across the country, I would like to thank you. The spirit that Dr. Sondi sir has brought, detailed discussion and dialogue. So you see the depth of detail that sir is sharing with us, and the selfless way in which sir has shared his experience and expertise with us. For this, sir, I am grateful. Everybody who is listening to you is grateful. And we thank you for your leadership in this field. Thank you once again, sir.
I'm kind of honored to be on the stage with you, Dr. Sanjay.
Yes, sir, we are all together, and our aim is a healthier and happier, more harmonious India. Thank you, sir, and Jai Hind. Jai Hind, sir.
Thank you very much.